Hello and welcome everyone to this session on the latest pheno trends and guidelines. I'm Hannah. I'm the Clinical and Medical Affairs Manager at Bevfont Scientific, and I'm joined by Carol. I'll let you introduce yourself, Carol.
Lovely, thanks Hannah. My name's Carol. I am a respiratory nurse by background with many years experience dealing with pheno, and currently I'm working with NHS Gloucestershire as their respiratory clinical nurse advisor.
Wonderful, thank you very much. So we'll dive straight in. Can you summarise the key updates in the new NICE guidelines and highlight the most significant changes that have happened recently?
Yeah, the guidelines are really interesting this time. So we've got a joint BTS signed NICE guideline at last, which we've been waiting for many years, and there are significant changes. So the changes around diagnosis are around the order of testing and the number of tests required. So previously we had a sort of a range of tests with differences between BTS sign and NICE. And what we've got now is a really nice, clear pathway. So the pathway tells us the first thing we do with adults is either pheno testing or blood eosinophils. If that is in keeping with the diagnosis of asthma based on the patient's history as well, that's enough to make a diagnosis. If the pheno test isn't in keeping with the diagnosis of asthma, so they're using 50 parts per billion with adults, then we move on to spirometry with reversibility. They interestingly say that if spirometry isn't available or there's a delay, you can use peak flow diary cards. So peak flow diary card for 2 weeks looking for variability. And if that still doesn't give you a result, then you are looking at challenge testing the patient. So I think the main thing is if one test gives you a positive result, one test is enough. In children, they are saying it's a slightly different order. They are saying pheno is the first test with no choice of anything else, which I think is fantastic. If pheno isn't conclusive, so 35 parts per billion for children, then we move on to spirometry or peak flow diary card, as I've said before. And if that isn't conclusive, then we move on to skin prick testing and blood tests. So that's quite different to what we had before. And I think it's going in the right direction. There are also significant changes in treatment. So previously we were always the blue and the brown inhaler. The blue inhaler has done its day and I think is going into the background. So the move now is towards using an air regime, so anti-inflammatory reliever therapy, which is a formoterol containing ICS combination. And that's where patients use it as and when necessary for very mild asthma. If they are using it regularly or they are more symptomatic or they have exacerbated, then we move on to a MART regime, so maintenance and reliever therapy. And again, formoterol containing combination used twice a day regularly and as and when patients need it. And then the suggestion then is that we start on a low dose MART regime. If that doesn't control symptoms, we move up to a moderate dose regime. And if the patient is still symptomatic, the guidelines are suggesting we do a pheno test. So at long last, they're realising that pheno is useful in management. And then the treatment depends on what the pheno result is. So that's the sort of top line stuff. Those are the big changes. So the big change is the ordering of tests in diagnosis, and the management, as I say, is hugely different. One of the things people are getting really nervous about is patients that are already on the older regimes. What do we do with them? And the guidelines are clearly telling us we only move those patients onto the newer regimes if they are symptomatic. And if they are symptomatic, then absolutely we change them. They are also saying, and they make a very clear statement, saying that salbutamol should never be prescribed on its own without an inhaled steroid of some sort. So the salbutamol-only regimes have gone completely out the window, which I think is excellent.
I know there have been some changes in regards to the cutoff values for pheno testing with the new guidelines. What are they and what's the significance behind those as well?
Yeah, so NICE have looked at the cost effectiveness of testing, and they've looked at where the cutoffs are and where it is cost effective to do the test. It makes me sort of smile a little bit because you don't know what the result's going to be until you've done it. So you don't know if you're in a cost effective region, if you like. But what they're saying is in children, the cutoff point, so if the result is over 35 parts per billion, that is in keeping with the diagnosis of asthma as long as the child's got the history that makes you think the patient's got asthma. And in adults, same thing. So history in keeping with the diagnosis of asthma and a pheno of 50 parts per billion or above.
The updated guidelines have been developed jointly with BTS and Sign. Why is this collaboration important, and how does it benefit healthcare professionals and patients?
In the UK, we have had guidelines that tell us to do different things. So we have had BTS Sign telling us to do one thing, and that is in diagnostic and treatment pathways. And then we've had NICE telling us to do something different. And most people will also have local guidelines that might be based on a mixture between the two. So I think there's been confusion, and I think patients that have asthma have had different approaches. Having a joint approach from BTS NICE Sign altogether means that there isn't that difference between the recommendations. It's very clear that this is the guideline that everybody should be following. So there's no pick between the guidelines that are available. This is the guideline. That means patients are going to be getting the same service wherever they are, which is as it should be, absolutely.
In addition to the introduction of these joint guidelines, I know some guidelines recommended management previously, and some guidelines only put more emphasis on using FeNO for diagnosis. I know NICE have recently introduced utilising FeNO for management in these new guidelines. Could you please also expand on that as well?
Yes. If you use FeNO, you very quickly realise how useful it is, and you very quickly work out for yourself if a FeNO test would be helpful to a patient. And the BTS NICE Sign guidelines have made sensible choices, I think, based on cost effectiveness and evidence. And they're saying about using FeNO in diagnosis, but they're also saying that patients should have access to FeNO in their routine management. And they are saying the times when you should do a FeNO test is maybe at their routine review. That might be around patient education, that might be around checking adherence, those types of things. But they also say, as I said earlier, about the cut-off point when you've increased a patient's treatment and they're still symptomatic, about doing a FeNO test before you make a decision about the treatment. And that's based on what are you trying to treat? If the patient is symptomatic, are you trying to treat bronchospasm, in which case it's adding in another long-acting bronchodilator? Or does the patient have unchecked eosinophilic airway inflammation, in which case you need to be tackling that? So making sure the patient's using the inhaler, using it properly, and if that's the case, thinking about biologics. So it's taking patients along that biologic pathway.
Yeah. Can you draw from a personal experience using FeNO, where using FeNO for asthma management has benefited you as a healthcare professional?
I think you're going in blind. So when patients are on a medication, and whatever that medication is, and you've checked their inhaler technique and they've got good technique, and you're confident that they're using it regularly, but they're symptomatic, you are best guessing what you think you're treating. So you've got the choice of either looking at tackling the bronchospasm, or you've got the choice of tackling the inflammation. And when patients are sitting in front of you, you don't know what it is you're tackling. And I've used FeNO for a long time in management of patients, and it has guided my treatment. So I can remember many patients that have come in that have been symptomatic, that have had a high FeNO, and we've needed to increase the anti-inflammatory treatment. And I've also can remember a number of patients that have come in symptomatic with a low FeNO, that they're only on the old regime of an inhaled steroid and a short-acting bronchodilator, where a long-acting bronchodilator is the thing. So instead of just guessing, instead of trialing a treatment, which may or may not be the right thing, and having to get the patient back to review them and starting again, it means you go the right way straight away. It's that piece of the jigsaw you don't have otherwise.
Yes, absolutely. So moving on to QOF, I know QOF is a very important topic for a lot of healthcare professionals. How do the new NICE guidelines align with QOF measures, and what practical impact do you foresee for primary care providers?
So currently, QOF isn't reflecting the new guidelines. That's not strictly true. So the changes have been made to the Quality and Outcomes Framework contract, but the negotiations with the BMA and et cetera haven't happened yet. So if you are working in practice, you won't see changes to the templates within your clinical systems because they haven't been agreed yet. So previously or currently, what we were asked for was spirometry and one other test, which could be FeNO, could be reversibility, could be peak flow diary card. What QOF has changed to saying is what BTS NICE sign guidelines say. So they are now asking for one test, and ideally that first test should be FeNO. So we should see a change, or we will see a change in what happens in the templates, which means that it's going to be much easier to achieve your QOF targets because you've only got to do the one test. But the clinical systems need to be changed to reflect that. And there's just a bit of a time lag in the process with that one. I think probably it will be when the new financial year starts in April. I think that's probably when we'll see the QOF in the changes in the templates in QOF in clinical systems.
How do you think these updates will affect reimbursement structures for healthcare providers throughout the UK and potentially globally as well?
It's tricky in the UK because the reimbursements outside of QOF, so QOF is what practices rely on for income to maintain the practice as a business. So I think it will be easier to achieve QOF targets. As I say, it will be one test instead of two. There are regions, so where I work, for example, we have a local enhanced service. So that's something we've negotiated within our ICB with our practices, and we pay a fee for a diagnostic FeNO. We're not paying a fee for an ongoing and management type FeNO, but we are paying for the diagnostic tests. And you will see that in some areas of the country. And in those areas, you will see appropriate activity. Beyond that, in the UK, I think, as I say, it is difficult because there aren't standard reimbursement systems. It might be something that comes in, but it's not something I foresee at the moment. I think worldwide, a lot of the world looks at our guidelines and looks to what we're doing and what we're recommending and base their reimbursement structures on that. So I think worldwide, you are likely to see a change based on the UK guidelines, which are recommending FeNO as the first test, obviously.
Looking at places like Germany, FeNO isn't very well reimbursed in the country at the moment. They put a lot more emphasis on cost saving rather than the clinical application and the value it brings to clinic. What lessons do you think we could bring from the new NICE guidelines to countries such as Germany for reimbursement?
Yeah, it's interesting how different countries look at different parameters, isn't it? But the NICE guidelines will need some time to bed in so that everybody is doing the right thing and the same thing. And I think we will be able to demonstrate cost savings based on prescribing, cost savings based on hospital admissions, based on unscheduled care. Those are the types of things actually in the UK we're really interested in as well. But I think just the fact that NICE has been involved in this process and NICE looks at the clinical evidence, but also the cost-effective modelling, so that they model how much things are likely to cost and they give you that sort of impression. And NICE have recommended this, and I think that's a really strong message to the rest of the world, that this is based on evidence and cost-effective modelling. And if we give it time to run, we should be able to demonstrate some of those cost savings as well.
What do these new guidelines mean for clinical practice in other countries, do you think? And are they likely to influence international standards? I know we discussed previously reimbursement, but how do these new diagnostic pathways and management pathways that have been embedded into new NICE guidelines, how do you think they could impact international guidelines such as ERS, ATS, German guidelines, etc.?
A lot of the world do look to what we're doing. They do look to see how we are changing and how we are recommending differences. And even though we don't make international recommendations and these are UK guidelines, I think the rest of the world are likely to be watching us to see what we do. They probably will give us a bit of time to see if we make changes by these new guidelines. These are quite a shift from the usual guidelines. And I think if we've made that shift, we are likely to influence the rest of the world. Certainly when you go to big meetings like ATS, ERS, we have quite a lot of UK data presented. So they are really interested in what we're doing. So I'd like to think they would be following the same sort of pathway. It's interesting because we've got GINA guidelines as well. So that's the global initiative in asthma. So those are international guidelines that say something slightly different, but moved this way a little while ago, really?
There are a lot of differences between guidelines throughout the world. Could you just give a brief overview of what those differences are, such as between ERS, ATS, NICE and GINA, as you've mentioned as well? I know some take a diagnostic only approach with Pheno. Some recognise both diagnostic and management approaches. So it'd be good just to look at that in a bit more detail.
Yeah, so international guidelines, you probably know more about this than I do, so I might bounce this question back to you. So if you look at the treatment guidelines, so the treatment is a big change. And when you look at GINA have recommended this pathway of treatment for some time, for a number of years, but they've offered it as an option. So they've said you can follow track 1, which is the AIR and MART pathway, or you can follow track 2, which is the more routine pathway, but making sure that every time the patient takes a puff of a short-acting beta-2 agonist, they take a puff of inhaled steroid. So there's been choice, whereas the BTS NICE sign guidelines are giving you no choice. They are saying, this is the pathway, this is what you follow. With regard diagnosis in the rest of the world, what's your experience? What have you seen in sort of ATS recommendations in ERS? Are they the same, or is there still lots of difference out there?
I think one of the biggest differences I see personally are the cutoffs for pheno values. There's a lot of inconsistency regarding that. And I think that was one of the, from my perspective, one of the biggest reasons they actually done the combined NICE, BTS and SIGN, because there's a lot of confusion over cutoff values for pheno. ATS, for example, they have this very over 25 ppb for adults, interpret cautiously pheno, and then you have this very hard over 40 ppb is definitely a significant airway inflammation. Whereas with the revised NICE guidelines, we now have this 40 ppb you can diagnose with other symptom evaluation as well. So what's your thoughts around that?
I find it quite hard. So we've got the current cutoff guidelines. So we've got 35 children. What age of child is that? So that's a little bit indiscriminate. So if I've seen 12-year-olds, when you drive past a secondary school, that are tiny little dots, and then you see these giant 12-year-olds. So there's going to be a difference in those. So there's a little bit of interpretation needed there. But I also find it quite hard. So if your cutoff is 50 for adults, so 49 is okay and 51 isn't. So hard cutoffs I find a bit difficult. I liked the previous ATS ERS recommendations around, and my interpretation of it was 0 to 25 was not demonstrating airway inflammation, so unlikely to support a diagnosis of asthma. Over 50 was, and that 25 to 50 was, as you say, you interpret that with caution. So I would like to think of that as my thinking zone. That is I'm not really sure about this. I'll think about the clinical history. I'll rethink about the patient. I'll give it a bit more context. And I don't want people to lose that. I don't want people to go from that to going, algorithms, okay, so 49 is normal, 51 isn't. You need some clinical interpretation in that. So I like guidelines that give you a little bit of thinking time, thinking zones. Yeah. And I do worry that people will do the 0 to 50 is okay and 50 plus isn't, and not think about the clinical implications. I also worry that people will not be taking proper histories and not have a high suspicion of asthma before they do the testing, and then find somebody with a slightly raised pheno that is for another reason and isn't in keeping with the diagnosis. So it is that whole pathway. It is around thinking about history and having some flexibility in your thinking.
I think, to quote yourself, pheno is very much just a piece of the jigsaw, isn't it? I think it's really important, as you say, to consider everything and not just one element of that. And I think previously with the NICE guidelines, they very much leaned on spirometry, which is just a lung function test. And I think we've previously discussed, if someone comes to clinic and they're feeling okay on the day and they take a lung function test, they take a spirometry test, it's more likely to be normal. But in some cases, you can still have raised airway inflammation, and they can still be in danger of having an asthma attack and having uncontrolled asthma. So as you say, I think it's really important to get that whole picture.
Yeah, and asthma is an inflammatory condition. Asthma is a condition that has eosinophilic airway inflammation at the very base of it. So it makes sense to make sure that that is what you're trying to measure. And I think blood eosinophils are okay, but blood eosinophils are a systemic measure of a localized disease. And going off a little bit on a tangent, I think the difficulty with blood eosinophils is that a blood test is perceived as a cost-free test. It absolutely is not cost-free. It costs somebody somewhere in the system, but it costs primary care in time. So I think the option that some practices will say is, we'll just do blood eosinophils. We don't need pheno. Well, you do because you need it for your children. And if you've got it for children, you can use it for adults. But if you do a blood test, you're going to have to send the patient away and get them back again. And one of the currency we're really poor in primary care is time. So I think to cut down on the time we need is really, important to do that.
Yes, absolutely. Do you believe the updated guidelines will significantly enhance asthma management and patient outcomes? I absolutely think they will, but it'd be great to get your thoughts on that initially, Carol.
Yes, absolutely. So 10 years ago, the National Review of Asthma Deaths, in fact, we're coming up for 11 years now, told us what to do differently and told us we could reduce the number of asthma deaths by doing the 19 recommendations that they made. But things haven't changed. And I think at the basis of the problem with asthma is firstly, getting the diagnosis right. And then secondly, getting an effective treatment regime that patients can and will use. And this is a real step change. This is a real shift in what we've done with asthma. And I think that's what we need, is a real shift to make a difference. And this absolutely should impact on getting the diagnosis right, treating symptoms and preventing death and disability. And I think those are really important. I think this is absolutely the right way to go, and it's taking a while to get there.
Yeah, I think just, on the whole, using pheno as that educational tool, I mean, how have you used that within your clinic to educate your patients and so they have better control of their asthma and using pheno?
I've got a very technical way to do that. So generally I say to patients, has anybody taken the time to explain to you what asthma is and how your inhalers work? And I would say at least 90% of patients say no, or maybe, but I don't remember. I then have a piece of paper and a pen, and I talk to patients about what asthma is in a very simple way. So I explain where their lungs are and how big they are. I explain about asthma affecting the airways, not the tissue of the lungs. And I draw a circle on a piece of paper and I say, this is representing your airway. I then draw another circle inside it to represent the mucous membrane lining the airway, which is normal. And in well-controlled asthma, that's how it sits. And then I draw a picture of an inflamed airway, showing the reduction in the whole of the airway. Then I draw another circle around the outside representing the smooth muscle. And I simply explain what asthma is, where the inflammation lies, and what the medication does. And then I do a pheno. So if I talk to them about inflammation and I say, this is what I'm going to measure, they can get the idea completely. So they can see what I've drawn, and it's really simple to do. And they can then get a really good a really good feedback that actually their airways are or aren't inflamed and what treatment they need to use. And actually, once you get that far, they work it out for themselves how they need to adjust their medication. And I would say frequently, it's not adjusting medication, it's taking medication. So they'll say, I need to take my inhalers more regularly, don't I?
Yeah, I think education is really key. It's key to ensuring those patients are effectively managing their asthma. The amount of people I've spoken to and have said, well, when I feel ill, I just take my salbutamol because that makes me feel better. But it's the underlying airway inflammation and the knowledge of what that brown inhaler does that, that is really key and really important to their asthma management. And I'm sure you've seen many examples of that yourself as well, Carol.
Yeah, and that's the perfect thing about the new guidelines, that we're moving away from that ability just to take a blue inhaler. So if the patient is on an air or a MART regime, every time they take a puff of their rescue medication, they get an extra dose of their anti-inflammatory medication in as well. So if they're hitting a bad patch and they're needing to use more rescue medication, they are by default using more treatment medication as well, more inhaled steroid.
Yes. What role does pheno testing play in the updated guidelines? I think we have covered that, but it'd be nice to summarise it as well.
If we look at diagnosis, the first line recommendation for the first test is a pheno test. And in adults, you've got the option of blood eosinophils, but in children, it is pheno. So it sits there. If that is diagnostic, if that's raised in keeping with history, that's it. And then in treatment, we're looking at routine, maybe thinking about doing it at the patient's routine review, and certainly before we make any changes with their medication.
Can you explain the significance of pheno as a biomarker for airway inflammation and its role in guiding treatment decisions? I think we have briefly covered this, but it'd be nice to just summarise the point again.
Yeah, so pheno is not a test to diagnose asthma. It is a test to detect eosinophilic airway inflammation, which is what sits at the base of asthma. So if you have a patient that is waiting for diagnosis or that is symptomatic, it is that test that tells us whether or not the patient has got eosinophilic inflammation.
I think you hit the nail on the head a couple of moments ago where you said, it's about not going in blind, and it's having that tool to be able to see that there is that airway inflammation there, and whether the treatments you're prescribing are effective as well.
It's always made sense to me. It's always been, why would you do anything blind when you've got the option to know? So it's always been a bit crazy to me that it hasn't been a routine part of asthma management, definitely.
Pheno testing is sometimes considered costly in primary care. How do the guidelines address its cost effectiveness in improving patient outcomes and reducing healthcare burden?
It's great to have recommendations from NICE that this is a cost-effective intervention. So we in healthcare are supposed to look to NICE to tell us what is and isn't cost-effective. And we know that this is a cost-effective intervention from the modelling that they've done. It is tricky in primary care. With primary care being independent businesses, it's who pays. So should the ICB be paying for it? Should the practice itself be paying for it? So it is tricky. But it is actually in any business case, whether it's to your practice manager, whether it's to your GP partners, whether it's to your ICB, it is really important to know the difference it makes to patient outcomes and the difference, the savings it can make along the line. And those savings may be prescribing savings, they may be savings in time, they may be admissions. So I think it's worth looking at all of those things, absolutely, to make a cost-effective business case to try and get it into your practice.
Do you have anywhere you would signpost people who are thinking of incorporating pheno into clinics? Is there any way you'd signpost that could help put a business case together?
So the Accelerated Access Collaborative of NHS England used pheno as one of the rapid uptake products a couple of years ago now. And we did see a huge increase in pheno across the country, which was fantastic. But it's still not across the board. And they have put together a whole load of documentation to help business cases, including a sample business case. That sits in two places currently. So it sits on the Wessex Health Improvement Network website. They are not going to be hosting it for much longer, but it's also sitting on the Primary Care Respiratory Society website, and it will stay there. So it's absolutely worth looking there for all of the tools that can help you with a business case.
Yeah, just touching on QOF and reimbursement again in the UK. I mean, it's a minefield. I think it's fair to say it's a minefield, and it's very complex. I mean, do you know of any, can you signpost healthcare professionals that are thinking of including pheno or maybe new to pheno and not quite sure on how to claim their QOF points in regards to pheno as well? Is there any anywhere that they can go to get any resources? Or
it should, so the clinical system, so whether you're using System 1, EMIS Web, Vision, whatever you're using, the clinical systems should have current QOF information on them. So anything, so on System 1, for example, if you're looking at an asthma template, anything that is a QOF code has a little asterisk by it. But the coding is really important, because if you don't get the coding right, you don't earn the points. So from a practical point of view, it should be there. It should be easily accessible. I think what isn't there is the information that sits behind that QOF headline, if you like. So one thing it will say is the patient has to have an asthma review, for example. If you look at the QOF documentation, it tells you what the asthma review should include. So it should include a chat about inhaler technique. It should include making sure that they can use their inhalers properly. It should include a count of exacerbations, those types of things. So you can find that document online. It's very easy to find if you just literally Google QOF 24, 25, 25, 26, whatever year you're in, you can find that document and it will tell you about all the diseases, and asthma sits within that.
I mean, how practical is it to incorporate pheno-testing into routine asthma reviews? And how much time does it realistically add to consultation? Because as we've discussed, time is a commodity, especially in primary care. So it'd be great to get your thoughts on and takes on that as well.
If it was free, everybody would do it. There would be no question. Everybody would absolutely do it routinely and include it in their consultations. Once you've got over the costing hurdles and you have it there, it's not a problem. So if a patient can do a pheno test at the first attempt, it takes about 14, 15 seconds by the time you switch the machine on and done the test. That's it. That doesn't add to your consultation particularly. Sometimes they can't do it first time. You might have to do it a couple of times. It's less than a minute. And the information that it gives you and the information to the patient around patient education is absolutely invaluable. It saves you a lot of time in the long run. It's just getting over the initial financial hurdle of getting it in-house. Once it's in-house, as I say, if it was free, everybody would do it.
Regarding cost effectiveness, how does pheno-testing compare to other interventions, considering its role in reducing exacerbations and improving asthma control? I know I believe the new NICE guidelines did touch on this as well, so it'd be great if you'd be able to expand on that.
There's increasing evidence now. So I think I did some research on pheno around patient acceptability and acceptability in practice in about 2006. So I've been doing it for quite a long time, but there's still not that much evidence. And it's really hard to equate a change and improvement to practice to one thing. So in Gloucestershire, we have seen a significant reduction in our patients being admitted for asthma, and we have pheno at practice level. But we also have respiratory champions at PCN level, and we have a real drive and passion to get it right. So that is hard to say that the one intervention has made a difference, but we know it has. I think looking at the evidence around those more broad things around reduction and exacerbation, around patient symptom control. I mean, patients live with asthma and just accept they've got asthma, they wheeze, they cough, they're short of breath, they shouldn't. And I think it's hard to measure those things. So I think it's the sort of thing you see on a day-to-day basis. And I think there's probably a need for more evidence around the difference it can make in the whole of the asthma pathway. But absolutely, I think the recommendation from BTS NICE sign that it is cost effective should be enough, but we need to consider what collateral costs, if you like, can be reduced and improved, and how we can improve patient experience.
Thank you, Carol. And I think final thoughts, if people looking at these new guidelines, what are the key takeaways they should take from these guidelines? And, anyone thinking about incorporating pheno into their primary care or their secondary care settings, why would you encourage that?
I think you can't do what the guidelines are telling you to do now if you haven't got pheno. So pheno plays a very central part in diagnosis and management of asthma. And I think from the whole pathway, if you're looking at patients when they first present, when we're looking at how we change medication, and then the other really important thing we haven't really touched on is making sure that we're referring the appropriate patients for biologic treatment when they need it, so we don't flood the system with the wrong patients and we don't get it wrong. So I think, as I say, you cannot implement the BTS NICE sign guidelines if you do not have access to pheno.
Well, big thank you to you, Carol, and thank you for everyone that's joined us today, listening, watching, wherever you are. If there are any questions, please feel free to reach out to us at clinical@bedfont.com. But thank you, and I look forward to speaking and seeing you guys soon.